Thank you, Professor Manoj, for that dissecting through the sonor anatomy of the brachial plexus. We will have questions at the end of this session. Professor Manoj and team have got a masterclass at 10:30. Bala, please.
Welcome to Professor Vincent Chan. He will be virtually present with us. Just 2 days before this meeting, due to unavoidable circumstances, we couldn't have one of the best friends for AORA, Professor Chan, with us. Good morning, Professor Chan. It's good morning for us and good night for you.
Good morning.
Over to the moderators to introduce Professor Chan.
Our next speaker really needs no introduction. Professor Vincent Chan is a giant in the field of regional anesthesia. He's a professor from Toronto in Canada. He has been a great supporter of AORA throughout the years, and we are indeed privileged to have him speak about point-of-care ultrasound.
So good morning, everybody. I'm really happy to be with you today. Greetings from Toronto. First, an apology. I am really sorry that I cannot come to attend in person due to some last-minute unforeseen circumstance that prevent me from traveling. I truly regret missing the opportunity to be with you all, to be with my friends, and to play an active part in this great meeting. By all accounts, I heard that this is a very big meeting. More than 1,500 people have registered, and congratulations to Dr. Bala and the planning committee for putting together such a exciting program with so many exciting topics and so many well-known speakers. I'm sure all of you will have a great time in the next few days learning and networking with each other. So this morning I'm asked to give a 20-minute presentation on point-of-care ultrasound, or we call POCUS. I believe this is the only non-regional anesthesia topic to be discussed at this regional anesthesia and pain meeting. This topic is dear to my heart, and I started learning point-of-care ultrasound about 5 years ago. I think it's really the time beyond needle guidance, beyond nerve localization, and apply ultrasound for other applications. When I look back at my journey in ultrasound-guided regional anesthesia, once I pick up the ultrasound probe, I can't stop learning. I cannot stop holding it. And I will bet you with point-of-care ultrasound, this is my second journey. With ultrasound, I believe it will be the same. For those of you who are young, you will pick up this skill very quickly, and you will find relevance in your clinical practice. And for those of us who are older like me, do not panic. Have no fear, because we can still learn new skills. So what I like to do, next is my disclosure. I receive an honorarium from Philips Healthcare, but that would not affect my presentation. So first, we briefly talk about point-of-care ultrasound. Ultrasound obviously is a visual imaging tool as opposed to a stethoscope, which only give us audio signals. It is a good way to, as a tool for extension of our clinical examination. It is point of care so that we can do it at the bedside. We don't have to. Now we talk about using it perioperatively. This is a technology to be embraced by anesthesiologists. Again, I believe this is the time for us to do that. A tool that would help us to get more information, to help us to care for our patients with more information. And now we also talk about point-of-care ultrasound, not just using it for cardiac application, scanning the heart. but also we can look at the body as a whole, the whole body point of care ultrasound. So this is truly an exciting area to explore, and for those of you who have not tried it, I urge you to do it. So this is the right time for point of care ultrasound because technology has matured to the point that the machines are getting smaller and smaller. Either is like a pocket size, phone size, your cell phone or a tablet, and some of the probe are connected to the device with a cord, but now some are even cordless. So it becomes very, very handy. Also, another development is I'm not a salesperson for Butterfly. This technology is available in the US. It's not available in Canada yet. But the price has really dropped to the point that I think many of us are now will feel that it's affordable. So I believe that in the next 5 years, many of us will have a point of care ultrasound in our pocket. After you pay this price every year, you have to pay a subscription fee. But the good thing about this technology is just one probe. It is a special chip technology that is able to give us a linear probe examination, a curve probe, and as well as the cardiac phase array probe. And you can simply attach to your cell phone. So this is very exciting for us to realize that more and more such technology, such devices are coming out, and we will make it very personal. So as we said, ultrasound, point of care ultrasound can be applied in a perioperative setting, and really you can use it for the whole body. Other than the traditional cardiac examination, looking at the heart size, the heart chamber size, the cardiac function, the valvular function, or we look at the vascular, the IVC collapsibility to judge fluid responsiveness. We can also now use it for non-cardiac applications. For example, we can use it for looking at the eye to check and monitor the intracranial pressure. This has been a very well validated tool in the neurotrauma situation, in the neuro ICU situation. We can apply in the airway to look at the airway. We can look at the lung, certainly, for pneumothorax, for interstitial syndrome. We can look at the diaphragm. And then we can look at the abdomen, whether it's the stomach or whether it is the abdominal cavity, look for free fluid, for example, bleeding in the abdomen after trauma. So all these, literally, we can apply to use point of care ultrasound to do. Again, the usefulness is, this is point of care, meaning you can do this at the bedside. So when we apply point of care ultrasound, we specifically talk about a very focused exam. This is not meant to replace a comprehensive exam by the cardiologist or other specialty. And we follow the I-AIM framework. I stand for indication. So obviously when we use it, we have a specific clinical question in mind. We want to have more information using point of care ultrasound to get more information. Second is acquisition. Obviously we need to know how to obtain a good image, very similar to ultrasound. To see the nerve, see the needle. And then the next I is interpretation. If we do not have an optimal image, we would get wrong information. And that's very important, particularly for point of care ultrasound. That's why we always talk about one view is no view. We have to use multiple views to substantiate the finding. And finally, M stands for medical decision making, right? Putting all these information together with your physical examination, with other laboratory data, you want to get the information you need to rule in a medical condition or rule out a medical condition. And if you are not sure, obviously we have to do a lot of training, a lot of practice until we are competent. So once we have done an examination, either we are sure that it is positive or it is negative. You rule in something, you rule out something, and also we should not be afraid to say that I don't know. It may be the situation is not serious enough that you have to do serial examination in order to find a positive finding. So first we talk about airway ultrasound. Right? Ultrasound with the airway, we can use a linear probe for anything superficial, or use a curved probe. You have a better field of view, you see more structures. And broadly speaking, you can scan anything above the hyoid bone or below the hyoid bone. So I think I have tried airway ultrasound for a number of years now, but one area of important clinical application obviously is to find the cricothyroid membrane. Okay. So because I only have 20 minutes and now probably less than 20 minutes, I'm just going to touch on, highlight some of the clinical applications that will be applicable and relevant to our regional anesthesia practice. So let's say you have this guy in front of you and you fail to his total knee replacement surgery, right? He is more than 600 pounds, and it's hard to find this type of individuals in India. But in North America, anyone 300, 400 pounds are not so unusual. So obviously, you have to give this patient now a general anesthetic. You worry about it, cannot intubate, cannot ventilate situation. So what are you going to do? You may want to, it's wise for you to make a skin marking to, in case of emergency, to perform an emergency cricothyrotomy. Right? So this will be very helpful in someone who has a difficult, fully defined neck anatomy. And in my, as a personal story, when I was a junior resident, a patient went into respiratory arrest in airway obstruction in the middle of the night after a carotid endarterectomy. And even the surgeon came to the bedside to rule out any carotid bleeding in the hematoma. It was just a general swelling in the neck. And he was not able to find the trachea to do an emergency tracheostomy. So I was thinking if I had ultrasound at that time, probably it would help us a great deal. So to look at the cricothyroid membrane is very simple. You can use a linear probe. I find it's most easy to put it in a longitudinal fashion. You look for the trachea. It's very easy to find the cartilaginous ring, which is dark. And here is the air mucosal interface. Inside the trachea is air. You won't see what's inside. You simply move the probe more careful cranial. You see you will see a very big hypoechoic structure. That is the cricoid cartilage. When you move the probe further up, you will see this bright line. Again, an air mucosal interface. This is the cricoid thyroid membrane between the cricoid cartilage and the thyroid cartilage. So you simply put a mark there. Will be highly valuable. Let's say you have now intubated the patient. He is so big, the airway pressure is high. You cannot really tell where the breath sound is. Again, you can use ultrasound to help you to find out whether the lung is being ventilated or not. So if you put a curved probe on the X-ray line, you will see this so-called the curtain sign. When the lung descends, you can see the curtain, the air, a column of air coming through, and it blocks all the visualization of the internal structures. So this clearly tells you the lung is moving on that side. You can also use a linear probe. I find it's actually easier, both on the left side and the right side over the mid-X-ray line. This is called a zone of apposition. And where you see here is the bright pleural line coming down. As the lung is inflated. You can see the pleural line comes down usually to interspace, and what you see here, this thick hypoechoic structure is the diaphragm. So when you see this coming down again, clearly the lung is being ventilated. So a very easy, simple way to What is relevant to us is after a supraclavicular brachial plexus block, the patients complain of shortness of breath without some oxygen desaturation. So your first question is, have I paralyzed the diaphragm? Are we looking at hemidiaphragmatic paresis, or have we caused a pneumothorax? Again, you can use the curve probe to look this time specifically for the diaphragm. Right? The diaphragm is this bright curved line here. This is the liver on the right side. When the patient breathes, the lung descend and the diaphragm is going to come towards the probe. So this is a qualitative assessment showing us that the diaphragm is moving. But after the block, if you see that during inspiration, the diaphragm doesn't move, it tells you that the diaphragm has been blocked. You can also do a quantitative assessment showing the actual excursion of the diaphragm, and you can do a very accurate measurement during deep inspiration of a sniff test. If there is a blockade, you will see a flat line telling you that the diaphragm is paralyzed, or it can be even paradoxical. The line can go the other way. So this is again very helpful to confirm the diagnosis. So now, next is our greatest fear is pneumothorax during anesthesia. The saturation has dropped, right? The oxygenation has dropped, and you don't know whether this is, you listen to the chest, there is decreased air entry on the left side, and you don't know whether it's the left-sided pneumothorax or the tube has slid too far into the right main stem. So what can you do with ultrasound? With ultrasound, again, we look for three important reverberation artifacts. The first one is lung sliding. Second is lung pulse. Third is the vertical artifacts we call the B line or the Z line. And when you do that, if you don't see any of them, you worry. You worry that it can be a pneumothorax, and the most specific sign would be the lung point. You see the lung sliding during inspiration, but it would not happen during expiration. And if you cannot see the lung point, then obviously you have to rely on other examinations. So remember that anything we do, we have to be very careful, because just the absence of lung sliding is not diagnostic of pneumothorax. The visceral fluid are not rubbing against each other because it's adhesion or the lung is too tight, then you won't see it. So this is what we call the lung sliding. It's a very fine shimmering movement of the lung pleura. And if you see in this situation, in these two situations, you don't see that there's any lung sliding. So that's what now we have to be careful. Not every time this is pneumothorax, it can be a very big emphysema COPD situation that you definitely don't want to put a chest tube into. As opposed to one lung ventilation, you will also have absent lung sliding, but the difference is that you have the lung pulse, which would clearly tell you that this is not a pneumothorax. So that is an important sign. I know my time has gone quite far, so I'm going to very briefly talk about gastric imaging. This is really to tell us whether the stomach is full of empty, whether we should go ahead with surgery or not. And we have learned to look at the antrum specifically because this is the most consistent area. What you're looking for is something underneath the liver. You will see that the wall of the stomach is very hypoechoic, the muscular wall of the stomach, and this is an empty stomach, so everything is collapsed. Right? As opposed to fluid, if it's distended with fluid, it's dark, it's easy, you can trace it. If it's a solid food, right after eating, it's a coat of air, so you cannot see what's inside. Wait for 10, 20 minutes. Now you can see what's inside. Usually it's heterogeneous, white and black. So you can qualitatively look at it. If the stomach is empty, both supine and lateral, you call it is empty, grade 1. If it's supine, it's empty, but as the patient turns to right lateral decubitus, now because of gravity, you can see some content, so we call it grade 1. The ones that you really worry about is the grade 2, when you see that it is distended both supine and lateral. And by scanning a lot of people, we are able to come up with this table. This is specifically for fluid, for right lateral decubitus. You can now map out the cross-sectional area, and then you will know how much fluid the patient has. Right? So all this is going to help you to decide, is the patient at high risk or low risk? If you see solid in the stomach, doesn't matter how much, it's high risk. But for fluid, if anyone greater than 1.5 mils per kilo, that's considered high risk. And finally, for echo, I find echo cardiography is the most challenging of all to learn because of the rib and also lung can be in the way. So you really have to do a lot of clinic, do a lot of practice. For anesthesiologists, I believe if you have an intraoperative cardiac arrest, the most important thing with echocardiography is to check whether it's really a true PA situation when you have seen no cardiac activity, or you can have pseudo PA, whether it's an MI, whether it's a massive pulmonary embolus or hypovolemic shock. And there's a so I think for all the ultrasound application, the important thing is we need proper training. We have to maintain a high standard, whether it is for regional anesthesia or point-of-care ultrasound, for any other applications. We need to make sure we interpret the information accurately, otherwise we can make wrong decisions. So for me, learning point-of-care ultrasound is like learning a language. We have to practice, practice, and practice, and we have to apply our knowledge and apply our skill regularly. And if we don't make ultrasound relevant in our daily practice, we would not be able to use this technology properly. So thank you very much for your attention. I know I have gone over time. I apologize. And if you have any questions, you can send me an email later on at my email address. Thank you so much.
Thank you, Professor Chan. Does anyone have any questions? Okay, I'll ask a question. Professor Chan, how soon in a training curriculum would you introduce something like point-of-care ultrasound or even something like an echo? How soon would it be in an early residency program, or do you require your trainee to be much older to introduce it into a curriculum?
At University of Toronto, we have now started the point-of-care ultrasound very early on the residency training. So every year, whether it's first year, second year, third year, and fourth year, each year they will have exposure to point-of-care ultrasound training. They may have 1 week. Some people would take a special elective for a 4-week rotation and spend time specifically with a mentor. And every day they will spend time in a recovery room or in the intensive care unit to scan patients and look at pathology.
Thank you. I think that's an important message, that as we move forward, we need to introduce these modalities early into our training programs. A lot of you are from the medical colleges, and this is one of the ways forward for us in India. We have a question. Dr. Angel from Philippines.
Hi, Vincent. I just wanted to find out what the sentiments of radiologists are regarding this incursion into their domain? Are you getting some resistance, or are they cooperatively working with you towards educating non-radiologists in this field?
We don't have zero resistance from radiologists. I can tell you that when we first started to image the stomach, they have no idea why we want to see it. In fact, our first study, we collaborate to find out what we should be looking at. For radiologists, they look at pathology. They don't look at the food in the stomach or fluid in the stomach. So our application is quite different. So this is certainly not a diagnostic. For them, it's not taking any business from them, so it's not a problem at all. Airway, again, is not a problem. Lung and diaphragm, again, is not something that we compete. The only resistance in some hospital is with cardiologists when you do a cardiology examination. But in North America, in the rest of the world, everything is about money. When we do these examinations, we are not charging the patient. We are really using the information to improve our clinical care. So if we don't charge, we don't compete with them, there's no conflict at all.
Thank you.
Thank you.